Outbreak management. An outbreak is defined as an increased number of cases compared to a normal baseline and is usually detected through surveillance. So what's the role of public health in outbreak management? So public health inspectors and public health nurses help manage outbreaks by giving assistance or consulting long-term care homes, giving them advice, provide recommendations for management, reviewing their policy and procedures, declaring outbreaks in long-term care homes or retirement homes, conducting surveillance and reviewing line listings, determine at-risk populations that may be affected in the home. If it's a point source outbreak, we can conduct an inspection of the source, so it would probably be food or water, conduct IPAC audits once a year or during an outbreak. Basically, we would just observe the staff and how they use PPE, hopefully properly. We can also provide corrective guidance to minimize transmission. We can also sit in on outbreak management meetings, collect environmental samples. For samples, homes have their own careers, but for food samples, we as public health should collect them. We should discuss administration of new residents, repatriation, so hospital admitted residents that need to come back to the home. Can they come back to the home? It's not really recommended during an outbreak. The resident might get the disease. If the resident left because they were a line listed case, they can come back because they should be healthy and fine. And it's important to note that new residents who want to live in the home can, but they should be put in a private room until the outbreak's over. Public health also reports the outbreak to the ministry and produces an outbreak report. Basically lists how many people were at risk, the control measures, and then the report should be sent to the home. So, steps to outbreak management. Number 1, we create a case definition. It's outlined in many documents, and we should really follow those documents for case definitions. But for enteric cases, we want to see a case definition for an enteric case is 2 gastrointestinal episodes, so diarrhea and vomiting, that are within 24 hours. For respiratory cases, 2 cases that meet the case definition. For COVID-19, a case is a positive test result from PCR or rapid PCR. So again, enteric cases, a case would be 2 or more episodes of diarrhea or vomiting, or 1 episode of diarrhea and vomiting is a case. Respiratory case is 2 or more symptoms produced in a patient. So the symptoms could be fever, headache, dry cough, a productive cough, or a sore throat. COVID-19 case is 1 positive PCR test in a hospital, positive PCR test at point of care, or a positive blood test of SARS-CoV-2. It's an uncommon test. So the second step to outbreak management are to review the cases to see if there is an outbreak. Are there no infectious causes? So we want to rule out things like medication. Are they producing these illnesses, these symptoms because of medication? And we want to ensure that the person fits the case. And then from this, we can determine the onset period. Step 3 is declaring an outbreak. When we suspect an acute respiratory acute respiratory infection, if it's suspected, a resident will get tested. If it's influenza or not, that's what we will go with for the outbreak. During the test, it determines if it's just a acute respiratory infection, COVID-19, or influenza. For COVID-19, we need to be in the setting for 4 days, and we need to see that they got the infection from the long-term care home or hospital. If not, then they got it from the community. For an enteric case, respiratory outbreaks. So a suspect respiratory outbreak is 2 acute respiratory infections within 48 hours in a specific area, so a unit or a floor, or more than 1 acute respiratory infection within 48 hours in different units or floors. Suspect influenza outbreak is 1 lab confirmed influenza case, or 2 acute respiratory infections within 48 hours, or more than 1 unit having multiple cases of acute respiratory infections within 48 hours. So in general, for suspect respiratory infections, it'll be just a regular acute respiratory infection, and then from there we can declare an outbreak. Once a lab confirms that it is influenza, then we can switch the acute respiratory infection into a influenza outbreak. So next, suspect COVID-19 outbreaks. Once one person has a positive PCR, rapid molecular or rapid antigen test, so the RAT test, and it was reasonably acquired in the setting, so it was acquired by someone who lives in the setting, it is a suspect case. For COVID-19, we need the case to be in the setting for at least 4 days, and we want to confirm that they got it from the long-term care home and not from the community. So respiratory outbreaks are confirmed once 2 cases of acute respiratory illnesses within 48 hours are observed with 1 lab-confirmed case, or if there are 3 acute respiratory illness or infection cases observed. So if there are 3 cases, we don't need a lab confirmation for there to be an outbreak. Once we test, it'll determine if it's influenza, COVID, or just a regular acute respiratory illness. More than 2 units having cases. So if there are more than 2 units having cases, it's a confirmed respiratory outbreak. And again, no lab confirmation is needed. Enteric outbreaks. A suspect enteric outbreak is 2 suspect cases of gastroenteritis in an area within 48 hours. A confirmed outbreak is 3 or more gastrointestinal cases in a specific area within 4 days. Again, so that's 3 or more cases of GI symptoms within 4 days, or 3 or more units having GI symptoms within 48 hours. In child care, a confirmed outbreak is 3 or more child cases within 4 days. The next step of outbreak management is starting the line listing. Homes will send it electronically now. Before it was sent by fax, and it is a form of surveillance. We want to determine if it's enteric or respiratory. So for line listings, there are 2 separate documents for enteric and respiratory, and they basically list different symptoms. We also want to get the health card number of patients, as it'll be quicker for us to get the lab results from the lab. We can just tell them the health card number. To maintain confidentiality, the line listing document will be password protected. There are also separate line listings for staff and residents. For COVID, we don't consider staff cases unless they got it from the resident or transmitted to the resident. For COVID, we want to also note for staff the last day they worked. So the next step for outbreak management is reporting to the ministry. Once we report to the ministry, we get an outbreak number. We get an outbreak number for COVID from CCM, and for any other outbreaks, we get it from IFIS. Step 6 is collection of lab samples. We want to notify the lab that there was an outbreak declared so they can effectively test the samples according to outbreak parameters. Step 7 is notifying public health labs. And once we do this, we submit the samples through an online portal. Homes can use their own doctors for submission info. Before, homes used to use the medical officer of health's name, but that's not the case now. There's also this thing called a multiplex test, and it tests for multiple respiratory viruses. So the next step of an outbreak management is review the IPAC procedures with the home. So we could review policy. We want to ensure that an outbreak notice posted outside the unit or home. This communicates to visitors that there is an outbreak and they should take extra precautions. And an important policy is for residents to stay isolated until symptom-free. So an enteric case is excluded until they are symptom-free for 48 hours. For respiratory cases, people are excluded until their symptoms resolve or 5 days from the onset of their symptoms. So for COVID exclusion, if the resident can't wear a mask or keep a mask on, they're excluded for 10 days since the onset of symptoms or since the positive test. If the resident can wear a mask, they are isolated or excluded for 5 days since their test or since the onset of symptoms. Other policies we want to ensure being followed are active surveillance. So is the home actively looking for new cases? We want to review hand hygiene procedures. It's the most important step to preventing outbreaks and transmission. We want to enhance the home's cleaning and disinfection procedures. We want to confirm what disinfectant are they using and how often is cleaning occurring. The minimum is once per day, but we can increase it. Another policy is we want them to stop admitting new residents. If necessary, if they have to admit a new resident, they must be notified that there is an outbreak and the resident has to be isolated so they don't get sick from the outbreak. We can also cohort staff and residents. So basically dedicate staff for ill residents only and dedicate other staff for healthy residents. So if it's a COVID outbreak, we want to limit visits to essential visits only. For COVID, we want healthcare providers in contact with the COVID cases to wear N95 masks. For regular respiratory outbreaks, regular masks will be suffice. So again, COVID, N95 mask, non-COVID, regular masks. And we can determine what PPE should be worn by doing a point of care risk assessment. So some PPE to be worn. For enteric cases, there's no aerosolization or droplets, so only gloves and gowns are required. So no mask required, just gowns and gloves. And it's up to the healthcare provider to conduct a point of care risk assessment to determine what PPE should be worn. For respiratory outbreaks, there will be droplets produced, so we want full PPE. So masks, eye protection, gowns, and gloves. Again, it's important for enteric. They just need gloves and gowns. For respiratory, you want full PPE, so masks, eye protection, gown, and gloves. So the proper steps for putting on or donning PPE. Number 1, perform hand hygiene. And then number 2, you put on your gown. Number 3, you put on the mask. Number 4, you put on the eye protection. And number 5, the last step, you put on gloves. So the proper procedure for taking off PPE are first to remove gloves and then remove the gown, then perform hand hygiene, remove eye protection, and then remove the mask. And then the last step is performing hand hygiene again. Environmental cleaning and disinfection. It's important to prevent indirect transmission, and it's important to note that surfaces should be cleaned or visibly cleaned before we disinfect. So disinfectants in homes, the recommended contact time for disinfectants is 5 minutes or less. Again, contact time, that's the amount of time the surface or thing needs to stay wet for disinfection to occur. The disinfections should have a DIN number to confirm that the label is approved by Health Canada. We want the disinfectant to be effective against norovirus, and which is very important during enteric outbreaks. So that is a intermediate level disinfectant. So some things to look for in the labels are, again, it's effective against norovirus, but they could also say calcivirus instead of norovirus. Ready-to-use products are more practical, and it's important to note that test strips can be used to test. And some disinfectants require PPE to be worn, and they should be stored and properly handled. The next step to outbreak management is if it's considered to be a common food source or water source of the outbreak, so basically a point source outbreak. Some signs of point source outbreaks are a spike of cases with similar onset dates. From that, we can suspect it to be food or water. And another giveaway is enteric symptoms. Enteric symptoms indicate that the source might be food or water. The next step to outbreak management is to complete a food safety inspection. So basically, if there are a lot of enteric cases, we can suspect that it's a point source outbreak from food or water. At that point, we can do food safety inspections and do tests of food. So long-term care homes have a retention policy that saves food for 2 weeks in case lab testing is needed. The next step for outbreak management is collecting food samples. It's important to collect hazardous food samples only and to consult PHO labs before submitting and notifying them that there's a food sample that are incoming. The food sample must be at least 200 grams, properly labeled and refrigerated. And the food sample should have been served 72 hours before symptoms. And based on this, we can make an attack rate table based on the food items. So how many sick people ate the food and how many healthy people ate the food. So just to review, attack rate is the proportion of people who became sick from disease. It can also be called the incident proportion. It is the number who meet the case definition in a period of time divided by the total population at the start time. So for example, gastroenteritis in a corporate picnic, 99 people ate potato salad in total, but only 30 people developed gastrointestinal symptoms. So we would divide 30 by 99 to get a 30% attack rate. We can also refer to, so back to food sampling, we can refer to the PHI Guide to Environmental Microbiology Lab Testing on the PHO site to correctly collect samples and to correctly fill chain of custody forms. The next step is admission or transfer of repatriation of residents. So residents coming back into the long-term care home. We can't approve anybody coming in. We can only just give recommendations to the home to determine if they want to let them in or not. Once we do this, we should cohort staff, giving private rooms for the infected to prevent more infections. We should monitor symptoms, and we should notify the residents coming back in of, an outbreak. The next step is communicating with staff, residents, and family. Communicating in homes helps everyone. It ensures everyone's on the same page, and poor communication can lead to increased health unit complaints, more misunderstanding, and lack of communication overall. We should communicate visitor policies and that they should wear PPE, and staff need to know what's going on during an outbreak. We want to ensure that management is communicating to staff and to ensure that staff have enough access to PPE and proper PPE training. The next step is an IFIS entry and update. So it's done only for respiratory and enteric outbreaks. It's basically a ministry reporting portal, and it lists how many cases happened during the outbreak, and also creates an epidemiology graph, and we should update it before we close the file on IFIS for an enteric and gastrointestinal outbreak. So the last step is declaring the outbreak to be over. An outbreak is over when there are no new cases for the incubation period plus the period of communicability. This will be different for different pathogens, but these are the general ones based on specific pathogens. So for an enteric outbreak to be over, we want there to be no new cases for 5 days, and this is based on the incubation period and communicability period of norovirus. For a respiratory outbreak to be over, we want there to be no new cases for 8 days, and this is based on the incubation and communicability of influenza. For COVID-19, we want there to be 7 days from the last onset date of the latest case. That's everything for outbreak management.